Okay, finally, airway management. Off to something. We still have a little anatomy, but we've already talked about it, so we're not going to spend much time on the anatomy. But the upper airway, the lower airway, remember the upper airway at the mouth, nose, air sort of warmed, humidified through here. Remember we talked about the nasal terminates, the pharynx, the throat, the oral pharynx where it connects to the throat, the nasal pharynx where the nose connects to the throat, and it ends at the glottic opening, or right under the epiglottis, correct? And then you have the lower airway where you have the vocal cords, the trachea, the bronchioles, the lungs, right? So that would be considered the lower airway. And we just finished with the anatomy review, so we won't really go there. I think we're good for right now. I do want to show you this quick video of a gas exchange.
Is called respiration and involves several events, including breathing. As we zoom into the body, we can observe the respiratory system during gas exchange. Air passes through the alveolar sacs to the alveoli, where gas exchange occurs. In this cutaway view of an alveolar sac and its capillary bed, the process of gas exchange is easily observed. During inspiration, atmosphere air fills the alveoli and gas exchange occurs between the alveolar and capillary epithelia. Oxygen in inspired air is represented as a white gas. Carbon dioxide in expired air is represented as a blue gas. Notice the change in color in the red blood cells during gas exchange. Now let's zoom into a higher magnification view of gas exchange at the respiratory membrane. Red blood cells in the capillary adjacent to the alveolus release carbon dioxide and bind oxygen.
No, real short, but so to give you that visual on how diffusion takes place, okay? We have different things. When we talk about airway and airway obstruction, okay, then we don't want an obstructed airway. We want a clear passage from the atmosphere into the lungs, right? That's called patency, or a patent airway. Patency, patency, I think it is, okay? But patency of an airway. When we have an airway obstruction, and we'll pick up more of this when we do CPR in about a week, we have foreign bodies, food, small toys, blood, liquid, vomit, obstructions that are obstructing something from going from the outside the air to the inside, right? So that's part of an airway obstruction that we get into. In an unconscious person, like in an acute would be sudden onset, where an acute obstruction would be if a person became unconscious, their tongue could fall over the epiglottis. In an unconscious person, the tongue becomes flaccid and it could fall over the epiglottis. Right? Chronic would be like someone with chronic bronchitis that always has mucus in their airway. Right? This is also considered an obstruction. There's that word patency that I was talking about. Did I spell it right? No, put an extra T in it. So patency over time. So edema from burns, trauma, infection, allergic reaction, decrease in mental status. There's a lot of things that we could talk about as airway obstruction. One of our major goals in patient care is to make sure that they have an open airway. Open airway. This is an important term because it's listed on the test. Like, what is the first thing that you do? You know, you should open someone's airway, correct? So the bronchoconstriction, like with asthma, everything else too. So the first thing you want to say is the airway open, or they have patency. It's very in a conscious person. It's very easy to see. I'd come up and say, "How are you doing?"
Good.
Boom, done. She can speak, right? The airway's open. If the airway was blocked for some reason, she couldn't be able to speak. She wouldn't be able to speak. So the part of your what's called going to be your primary assessment, okay? Primary means first. There's a few more steps to it, but once we get in contact with the patient, your primary assessment or your ABCs. What do you think A stands for? Airway. B, breathing, and then circulation. So ABCs. In a conscious patient, this is one of, not the first thing that you do in patient assessment, but very quick. You would do your ABCs. It's very easily done because of the fact that, can I borrow your wrist again? So let's just say you're my patient. I come up and I want to do my ABCs. So the first thing I'm going to do is I'm going to walk up. I'm going to say, hey, my name's Randy. How are you doing?
Good.
Boom, done. ABCs are done. Okay? Because in the back you didn't see me, but I reached down and I grabbed a radial pulse. Okay? So I felt a pulse, which is C. Okay? And she said, fine. So if the airway is open, they can speak. If they can speak, then they're breathing. Right? You have to be breathing in order to speak. You have to push air out. So that's done within seconds. So you just say, introduce yourself, feel for radial pulse, ABCs are complete. So we have to determine, is the airway open, and then will it stay open? That's an important part as well. So in a conscious person, this is not usually a problem. In a semi-unconscious person, this could be a problem. Will this stay open? Will the airway stay open? Okay, that could be an issue. An unconscious person, it is an issue. They may have an open airway, but will it stay open? So these are diagnostic type questions that we have to do. There's two ways to open the airway in a unconscious patient. It's the head tilt, chin lift, okay? Or in a trauma patient, it's the jaw thrust. So we look at this, and let's say Fred the head is up here. We have Fred here, and he's unconscious. There's a few more steps that I would do that I'm not going to plug in right now. We'll add these later. I'm at to the point where I want to open Fred's airway. Okay? So he's a atraumatic patient or no trauma. So I'm going to get him on his chin and lift and push his head up. That's the head tilt chin lift. So here and then push up. Head tilt chin lift. What this does is it mechanically pulls the tongue off of the epiglottis. Okay? It pulls it back off. And then I would go through the process there. But right here is just, remember, step processes, right? So the first step is to open the airway. There's only two ways to open the airway. Head tilt chin lift that we're going to learn. Head tilt chin lift and jaw thrust. Jaw thrust for the trauma patient. Head tilt chin lift for the unconscious atraumatic patient. Because we'll learn this next week or so in CPR, but on an unconscious patient, you actually do CAB, circulation, airway, breathing, okay? So, but you can almost do it all at once. So I would check a pulse, which would be C, and then head tilt chin lift. If they don't have a pulse, then I would immediately start CPR, okay? But that's for another day. Okay. But to open the airway, it's just a head tilt chin lift. Unconscious person, CAB. Conscious person, ABCs. Just takes seconds to do. All right. So it's not a huge thing. What we do is a step process. Like I said, there's a couple more steps I want to add in there later, but we're talking about airway management right now, not patient assessment. So just want to do a couple of things, but with the airway. It has to stay open. Can you imagine not having an airway, not being able to get the air from the outside in, right? It is your priority to make sure that they have a patent airway, that their airway is open and it will stay open. There's other problems indicating airway problems, okay? The inability to speak is a full body airway obstruction. So we look here for a possible full body airway obstruction. Could be a stroke, but full body airway obstruction, okay? They could have a raspy voice or something, a stridor, a snoring, a gurgle to it, which would indicate fluid. But all these things we're just introducing terms right now. We're going to pick these back up when we get more into the airway. If they're making a sound, then they don't have a full body airway obstruction. Does that make sense, everybody? So if they can't make any sound at all, especially a conscious person, they're not making any sound at all, they probably have a full body airway obstruction, and that's where we would do the Heimlich. So you get these other airway problems. All these we will introduce later, okay? But foreign bodies are a big thing. The chest wall, the tongue is a big thing as far as airway blockage. You have to look at then chest wall movement. Is there any chest wall movement? Are they breathing? Right? It's easy, like I said, on a conscious person because they can speak to you, so you know they're breathing. Or are they abdominal breathing? So these are inadequate. That's a big word there too. Circle that word because you'll see that a bunch. It describes somebody that doesn't have a good airway. Inadequate airway means that either they're not getting enough air in, they're not able to get enough tidal volume, right? Remember that term, tidal volume? It's how much we breathe in one inspiration, right? Or they may just be having difficulty breathing with asthma or emphysema or a respiratory problem. Okay. The same way with adults, you have retractions in the neck. They would, neck, and these are would be considered accessory muscles to breathe in. We have to be careful here because we don't want to branch off into a respiratory lecture, right? But you have retractions where they start retracting the neck, they start belly breathing, nasal flaring, people with respiratory distress, their nares flare out so they can get more air in. Okay. So when we look at it, right now, all we're looking at, okay, is whether or not that patient has a patent airway or open airway. Okay? And the way that we do that, one is in a conscious person, ABCs, in an unconscious person, CAB. But the primary way in an atraumatic patient to open the airways under the chin and head tilt chin lift, mechanically sort of pulling that tongue off the epiglottis. Now we say, will it stay open? I don't know. But as long as we're holding their head won't stay like Fred's here, okay? It will come back down. So if they're unconscious and you want to open their airway, you have to do this, okay? When you breathe for them with the bag valve mask, you have to have a head tilt chin lift. You have to keep their airway open. Now later, we're going to learn about this. It's called an OPA, or oral pharyngeal airway. Okay, this device here just keeps the airway open. It hooks back on the back of the tongue. Okay. Patient laying like this, right? So what this does is you would insert this OPA, for easier terms, or an oral airway. You would insert this by doing this and then rotating it here. But what it does is, can you see how that grabs the back of the tongue there? And it keeps the tongue off of the epiglottis. This is called an airway adjunct. It helps. An adjunct is a helper. So it will grab the back of the tongue and keep it open. That way you don't have to be here all the time, holding the airway open. There's different sizes. because we're different sized people, right? So without getting into this, because this is not really where I want to go, but you would take like if you were King Kong, you would use this airway, this for a big person right here. But what you do is you measure from the tip of the ear to the tip of the mouth. It's the measurement on that. And then there's certain indications on why you would use this, and certain contraindications, contra meaning against, why you wouldn't use it. Right? One of the contraindications is in a patient who is conscious. You wouldn't use this in a conscious patient unless you wanted them to vomit. Right? So essentially how this goes in, I do a head tilt chin lift. I place it on top of their tongue. I rotate 180 degrees and just push it in there, and it sits in there like so. And you're able to suction through it. That would get to next time. Okay? And now I free up my hands, because if it's properly placed, it's holding the tongue off the epiglottis. If I use one that's too small, it'd be like a toothpick, right? It's not going to do anything. Okay? Too big, I actually push the tongue back on the epiglottis, or it doesn't do anything at all. It hooks too far back over there. Too small one too, like this one would actually push the tongue back over the epiglottis. So we measure it for a reason. We want to make sure that we have the right size. You guys have any questions about the head tilt chin lift? Everybody good? Now the jaw thrust is a different. For the trauma patient, you actually sink your hands into where the mandible meets right here, this little hinge. Okay? In a jaw thrust, you take this, you put your fingers there, and you push down on the jaw. It'll make more sense when we're able to practice that a little bit. And this sort of does the same thing. But here, you would want an OPA pretty quick, because you would want to do this. Okay? But for test purposes, unconscious patient, atraumatic, open their airway using a head tilt chin lift. Trauma patient, unconscious trauma patient, open their airway using a jaw thrust. This has nothing to do with oxygen or anything. This only has to do with the patency of the airway, to keep the airway open, so you have an open passage from the atmosphere into the lungs. Okay. So there's a way in. Does that make sense to everybody? Everybody good with ABCs? Airway, breathing, circulation? CAB? You good with those terms? Okay.